Thank thank you, Roxy. Thank you, Nant, for this opportunity to talk about dialysis access and really and kind of have this discussion with individuals who are at the front line and managing these patients on a daily basis. So the topic for today is I found something wrong with this fistula or graft. What should I do next? Most very relevant clinically and procedurally in terms of how we manage these problems. So just a couple of things. If you have any questions, feel free to stop me in the middle, raise your hand and ask that question and or put it in chat and Roxy can pull that question up for discussion. I will be using a online poll. So I'll give you a minute to see if you could scan this QR code with your phones. This should come up in all the slides that have a question. Uh, you can answer them anonymously, or you can identify your name on the login part of this web poll. It does not get any other information other than the name that you put in there. So we'll start off with a question that should be relevant to this question, to this talk in terms of what are the most common problems that you see with dialysis access. So feel free to scan the code if you haven't done so and type up anything or everything that you get wrong. And you can put in multiple responses as well. So scan the QR code and see if you would put in. So clotting, erosion, that would be scarring or swelling on the fistula or the graft surface. Cannulation becomes difficult when the access is deep. Okay. Please keep adding any other responses or problems that you faced with your patient's fistula or graft. The more problems we have, the more we can talk about. Aneurysms. Okay. So yeah, I think those would be the most common problems that we will see, infections as well. Um, so we all know that we have different options for how we can dialyze our patients. We have a couple of superficial cephalic veins, the cephalic and the basilic. The basilic needs to be transposed in the upper arm. In the forearm, you can use a cephalic. Or we have an option to place a graft where we connect basically any artery to any vein as an outflow and use that conduit, whether in a loop formation or in a straight formation, a straight configuration, to then be able to get access to blood, which helps us get the patients on dialysis. Now, the problem is twofold. One, we struggle to get patients adequate access flows at the start of a fistula. A graft usually does not have that problem. So 95 out of 100 grafts that are placed, or 99 out of 100, should be working off the back. The fistulae, on the other hand, can have problems as they start. But once you start cannulating them, they do have some troubles and problems that come up. And some of the frequent problems that I see is where the nurses and the techs have had problems cannulating their graft. So let's try and see if we can answer this other question. What is a medical term that is used to describe narrowing of a dialysis fistula? Let's see if I can see how many of them. Okay, we got one answer, which is stenosis. Perfect. So some of the common problems that I hear all the time are what you pointed out earlier, clotting or pulling clots out of this axis, or there is a erosion or a scar over that axis, and how should I proceed? The axis flows are low, and how do we monitor those? Or the patients may have hand pain, or they have neuropathy versus severe pain when you cannulate, or even without cannulation. So all of these problems are chronically seen in patients who've been on dialysis. I'm going to take a minute and just go over the difference between a artery and a vein. Uh, the artery has a much thicker muscular layer compared to a vein, which normally does not have a thick muscle layer, but does have several valves in between. And the unique anatomy of this vessel, the vein, which is used to create the fistula, especially the valves, can create some degree of stenosis in the channel. And also, as the fistula matures, the vein is supposed to dilate and get thicker and bigger. So now the vein looks very similar to the artery in terms of the thickness over time and is able to then accommodate those needles in multiple process. Now, whenever we get a patient referred to us for a access problem, we have a host list of causes: the increased bleeding, low URRs, or difficult cannulation, or there is swelling of the extremity. There could be an infiltration and a hematoma, or the pressures are usually high, and the patients are not able to get the desired access flows that they need for auscultation. Now, one of the things that we should be doing in every patient as we start the process of dialysis, or when we examine a patient with a problem, is we really looking at what their access sound like. A good fistula should have a continuous buzz or a hum, which should be like a whooshing sound that we just heard. The sound is continuous in both the systole and diastole phase of the heart sound. So if you hear it in systole, also hear it in diastole. If you do not hear a sound, or if the sound is, it used to sound like that before, now sound is sharp and as you move your stethoscope from one area in the fistula to another area, the sound suddenly changes. That is a sign that could point to a stenosis. If you do not hear any sound, normal fistula, the stenosis, the sound is fading. And now there is no sound at all. There is a strong pulse, good sound, good flow, intermittent sound, systolic predominant, stenosis. No sound means the fistula may have clotted. Even if you feel a strong pulse, you should be cautious about sticking that fistula unless you can prove this flow. Another thing that you can do whenever you are cannulating the fistula, or before you cannulate the fistula, is do this simple 1 minute test, as long as your patients can comply and are able to move their hands rapidly. If a fistula has a stenosis anywhere in the circuit, in this patient, this is a radiocephalic fistula, then anastomosis looks good. There's blood flow coming into the fistula, but somewhere in the middle of the fistula, there may be a stenosis. If you raise this arm up vertically, the fistula should completely collapse. If there is a stenosis in the middle part of the fistula, the part which is proximal to the stenosis, closer to the heart, will collapse, but the part which is distal to the stenosis will stay distended, right? So let's kind of look at it in a couple of examples on patients that we.
Cephalic fistula is well distended. You don't see any visible hyperpulsatility. This is a good sign. We are going to demonstrate arm elevation test, and if the fistula collapses, that would mean that there is no major outflow problem in the fistula. So I'm going to raise her arm up now and see this part of the fistula collapsing really beautifully. So that means there is no outflow obstruction. The blood is having no problem flowing back to the heart.
If you watch this video carefully, the proximal part of the fistula collapses, but this little distal segment is still dilated, and it's likely that this is going to be pulsatile, and there's probably a stenosis right at this segment, which could potentially cause this distal part to keep growing or cause less flow to come into this proximal part, which could cause collapsing of that part of that fistula, right? Let's look at another patient. This is a new fistula that has never been cannulated.
10th of December.
Make sure you ask
Lift
the
your arm
patient
up.
that they have no problems when you elevate their arm. Lift the arm up. Fistula gets nice and soft. You can palpate it as you do that. You bring the arm down, fistula gets nice and full. A simple test can help
10th
us
of
rule
December.
out a stenosis in the axis. Now, as I was preparing for this talk, I started looking at some of those resources, and I came across um, nurse Lindsay Sippel's Facebook page, and she's got about 16,000 subscribers. And this is a shout out to her because I think she's been doing a lot of good work in raising education about patients with dialysis problems. So I'm going to share a couple of her videos to highlight some of the ways.
It's been my experience that the best dialysis clinics to work at are the ones where you can't really tell the difference between the dialysis nurse and the dialysis tech because they are working so well together, but there are significant differences in their role. One of the most significant ones is the pay difference. The nurses make more than the dialysis techs, but the dialysis techs are vital to a healthy dialysis clinic. They are in charge of water safety, they manage the fistulas, they manage the catheters, they are experts at the machines, where the nurses, they will help with a lot of those things. They help me, they teach me a lot, the dialysis techs, and I'm so grateful for them, where the nurses are more in charge of calling the provider, doing the assessment, choosing the fluid goals, and giving the medications.
And she's absolutely right. I think the best dialysis units in terms of the care that I see, we round at more than 16 dialysis units in this region in Shreveport, Louisiana. And there are units that have really cohesive team, and there are units that struggle to come up with that, kind of atmosphere in the unit. So yeah, what you pointed out is absolutely right. There should be parity in pay. So she has highlighted a lot of these problems when the patients come in with dialysis access issues. I'm going to play a couple more of these videos, and I'll let you kind of listen in.
Hey, how you doing? Yeah, let's take a listen to this fistula. Oh yeah, everything's fine. I just don't hear the bruit. Ramona?
So the moment you don't hear a bruit, you need to be worried about thrombosis in that patient, and that needs to be escalated to a higher level of investigation. And I love the fact that she is a very strong proponent of getting ultrasound in every dialysis unit. Quick question out there. Are there ultrasounds in any other units that you guys are working in right now? Please feel free to put that in the chat. So let's listen in.
The one thing I would bring would be the ultrasound, 100%, before like gauze and the tourniquet, because if I'm on a desert island, I'm creative enough that I can make like a tourniquet out of like a long leaf, and like that could also be gauze.
Yeah, so if you end up being in a unit where there's nothing else, you do want an ultrasound. All right, let's say a quick question on the poll. Looks like we only have one person who's joined the poll. So if anybody else wants to join the poll, scan in the Slido QR code. It's completely anonymous. You don't have to enter your name. And See if you can answer along. Which is the most common cause of infiltration of a dialysis fistula? Oh, excellent. Needle dislodgement, right? So if you do not get the needle in the right space, you will have problems with flow during that process. So here's an ultrasound of a patient that had problems with quote unquote pulling clots or having difficulty sticking. When the dialysis needle goes in, it's very small window of where the needle needs to land into. The axis could have a diameter of about 6 millimeters. And in this patient, you could see that the posterior wall has had some infiltrations, and there is a clot that is sitting on the posterior wall with that infiltration. So if the needle would go into this posterior wall, you will not get flow. You will pull clots out of that axis. Here's another example of another, needle cannulation with infiltration into the posterior wall. You can see there is a clot which is not completely occluding the axis. The upper part of the fistula is flowing. So when you listen to the flow, it should be continuous, and it may be without any change in the auscultation. But then the ultrasound can really help us understand that there is risk of infiltration in this patient, and we may need to get a little better understanding of cannulation in this patient. Okay. Let's take another question. Now we have a few more people up there online. So what increases the risk of infiltration? Calcium levels, exercising the fistula, high protein diet, or the blood vessels are fragile? Well, excellent, right? If the blood vessels are fragile, they're going to break more. So
It's spraying. But you can see my syringe is filling up. And as I advance, and see I kind of went down the bottom, I'm getting a drip down there. So I went through the fistula.
So this is a great model that she has on a couple of her videos where she uses these long tubular rubber band or balloons to help illustrate that you could very easily go deep and puncture the back wall. And this little pool of blood is the hematoma that's forming behind the fistula as you get that back wall infiltration. So let's keep watching.
That might not stop. And as I released, when I came back out, I kind of felt it let go. So then I'm able to advance that needle the rest of the way. Okay. So this is not a perfect cannulation, but see, maybe I went too fast. I pulled back and I'm getting a lot of air. I think I kind of ran out of blood in there, but that's why I made a lot of fistula. So let's take this needle out and let's try again with this other fistula. I'm gonna anchor this and I'm going to start cannulating. And as I cannulate, this has enough pressure, so I'm going to see blood return in here. So that's more than I even asked for. So I'm going to put the needle in, the bevel's up, I'm gonna advance it. And now I'm going to go slower. Okay, going nice and slow. There, and I got it, and I got a good blood return. See, I don't have a lot of flow in here, so that's kind of collapsed on me, but if I put it back in, I can see that I'm in that fistula.
So this is a great way of understanding that we got to keep practicing these cannulations. And this is another good example of.
Let's cannulate. I'm going to insert my needle into the fistula. And once I'm in there, I should see a blood return. You're going to see a pulse. So it's going to go boom, boom, boom. That's how I know I'm on the right track and I can advance my needle further. Once my needle's in, I should still get that pulse. Boom, boom. If you're not getting a pulse, people might recommend that you try flipping a wing. That's what I'm doing here, and it just changes the tip of the needle a little bit to help with blood flow into that needle. Once I know I'm in the right spot, that's when I am going to tape the needle down. Best practice is to have the wings lie flat like that, but if I'm being honest, the majority of my needles have a wing flipped. It just works better. And I love this visual because you'll see my needle move. You'll see that needle move, and that kind of shows us why it's important to check placement after we tape the needle down too.
I'm just going to back up a little. So at the end of that needle getting secured on the patient's arm, you see that the tip of the needle is now hitting the wall of that vessel. And this is where you will have difficulty in outflow. So I love the fact that she's not flipping the complete needle, but she's just turning the needle on its side to the left or to the right. What you're doing by that process is moving the bevel away from the wall, and that should get the flow going easily. We also got to recognize that when you cannulate the fistula, you have a very narrow window. The back wall is only millimeters away from the total cannulation zone, which can be, say, 8 or 10 millimeters in many of the fistulas. Another problem that another way that we can avoid some of these problems is just kind of dispersing the needle stick or the entry area throughout the fistula. So this is a nice description of a brachiocephalic fistula. You have, say, arterial needle cannulation site 1. So this would be Monday of week 1. This would be Wednesday. This would be Friday. This would be Monday next week. This would be Wednesday next week for arterial. This would be, Friday the second week. So for 2 weeks, you've scrubbed 6 different areas, and then you've gotten back to 1. Now, the challenge here is the patients sometimes do not allow you to do that because they want the comfort of going into the same area, because the scar tissue that forms is less painful than the healthy skin. But sticking in the same area is one of the big reasons why we develop some of these problems. All right. So once you keep sticking in the same area, that's when you have a high risk of aneurysm, or if you have a block in the outflow, you have a risk of aneurysm. So this question is, what is an aneurysm in the context of a dialysis fistula? Is it a rupture, a blocked vessel, a bulging of the vessel wall, or a narrowing of the vessel? Okay, so we've got a bulging of a vessel, we've got the complete rupture. So it can be a complete rupture of a vessel as well, but most of the fistulae aneurysms are a bulging of the vessel wall, where the vessel wall becomes really weak and it starts expanding in size. At times, you can have a complete tear of the anterior wall of the fistula, and you can have a large swelling below the skin. So let's kind of take an example of a patient that was recently referred in February of this year. The patient has a cephalic vein anastomosis, a radiocephalic fistula. On exam, everything looks good. There's good augmentation, but the fistula is really soft and the flow does not seem right. Another thing to recognize is the dialysis techs are very good at recognizing patients who may have a problem with cannulation. And in one of the studies which looked at, how often was it recognized that this is going to be a problem by the tech, and how often did we find the clinical problem? There's a fairly 9 out of 10 correlation for that. So this particular patient was identified and sent back to the dialysis access unit. So the first thing we do is ultrasound, right? And this is why if you have an ultrasound in the dialysis unit, this is something that we can do bedside. So one of the things that we've started doing in our practice now is every physician that goes out to the dialysis unit carries a butterfly ultrasound with them, no endorsements for any particular device, but a handheld device for ultrasound. And you can look at that patient's ultrasound in real time. So you can look at the anastomosis, see what is the anastomosis like. You can see that the vein hasn't really matured fully. The size of the vein is still about 0.4 centimeters or 0.5 centimeters. So 4 to 5 millimeter vein, which is not mature enough to be cannulated. And you can check the flow of the axis, and the flow is about 400 ml, right? So the flow is low and the vein is not dilated. You're not going to cannulate the fistula. So now you bring the patient back in, you do a quick angiogram, you refer them for a procedure, and you're looking at the anastomosis at that proximal radial artery, and you can see that there is a stenosis which is pointed by the red arrow. You can open up that stenosis with a quick angioplasty, and within a couple of weeks, the patient had the fistula ready for cannulation. So identifying a low flow can help pinpoint a patient who may have a stenosis in that circuit. And remember, the dialysis circuit is all the way from the heart back to the heart. The dialysis axis is just a little conduit in between. The problem with an immature fistula can be in someone who's got a very weak heart to begin with. And ideally, in those patients, you may not even, get AV fistula. You should not place an AV fistula if the heart is really weak and cannot accommodate the higher flow that it needs to push to get the fistula flowing. But if the heart is normal and the inflow arteries are all good, then you need to check that with an ultrasound on that axis and see if there is any intermediate or any obstruction in between a stenosis which needs to be fixed. There's another patient that we just recently saw who had a vein graft placed. And then when they started cannulating about a month later after the graft was accessed, they were pulling clots and sometimes they were pulling clear fluid around that graft. When you palpated the graft, it feels really good. Auscultated the graft, there is good flow around the graft. But when you do an ultrasound, you can see the graft has a nice open wall, right? But so this is the graft, where there is a area of edema or swelling around the graft. Now, this could have been because of a hematoma that occurred with back wall cannulation, but there's also fluid on the top of the graft. So this would be a graft that really hasn't incorporated into the vessel. The vessel wall has not incorporated into the subcutaneous tissue, because as the subcutaneous tissue grows into the vessel wall, there is no potential space left there. So when you puncture the graft and you take the needles out, the bleeding is not going to spread around the graft. So this particular patient, you just need to leave it alone for another few weeks, let the graft completely incorporate, repeat the ultrasound, and make sure that that space is completely closed, and then start cannulating the axis. Okay, I say it looks like it's time for another question. Just trying to make sure everybody stays awake. All right, what is the primary treatment for a ruptured dialysis fistula aneurysm? Start the patient on antibiotic therapy. Start the patient on physical therapy. Call the friendly dietitian. Call the friendly surgeon. You're right. Call the friendly surgeon. When there is a rupture, you got to get the patient in fast. All right, we got a leader. Arlene has gotten 3 out of 5 right and is the fastest answer. Good job, Arlene. So the aneurysms can be, again, different shapes and sizes, right? They could be in the cannulation area, or here, recognizing that big aneurysm, the people, somebody started cannulating the distal segment. Now the key thing here is severalfold. You want to make sure that those aneurysms are not thin-walled, and you can do that by completely occluding the fistula at the inflow and then slowly rubbing your fingers over that aneurysm to see what the thickness looks like. And also see if there is any thrombus inside those aneurysms. If those aneurysms completely collapse when you occlude the inflow, that means they have no thrombus. If they do not completely collapse, that means they may have a clot that you can pick up. Now, ideally, if you have an ultrasound, you should be able to do a quick ultrasound and get that answer. How thick is the skin above the aneurysm, and what is the risk of rupture? Anything that's less than a couple of millimeters has a high risk of rupture and should be sent in right away for surgical repair. Here's an aneurysm that is looking necrotic. The top of the skin is getting necrosed. This is bound to rupture eventually. Here is a rupture of a fistula, and there is a big dilated fistula right below the skin, and that needs to be emergently taken care of as well. So aneurysms and ruptures are not something that we can leave alone. Okay. So far, no questions. If there are any questions, I'll be happy to take. No. Okay. So here's another patient. This patient was admitted with a clotted axis not too long ago, right? And the patient had a declot done, and the nephrologist who had done the procedure had placed a stent at the cephalic arch, but also stent in the body of the fistula, or just above the body of the fistula, because there was some persistent stenosis. So after the angiogram is done, there is good flow. The thrill is really good. You auscultate. The patient went back to the dialysis unit, and they can see that the patient has really good flow. But then when they started cannulating the patient, they just cannot get blood flow, and they're pulling clots. So bring the patient back for an ultrasound. You look at the arterial anastomosis. That looks perfect. The artery looks nice and big, dilated. It's almost a 6 millimeter artery. The arterial anastomosis is nice, wide open. You look at the distal part of the fistula, and they have no problems placing a needle in the distal arterial part of the fistula. The fistula is about 15 millimeters wide and less than 3 millimeters deep, right? But in the middle part of the fistula, you start seeing a hematoma. The fistula gets a little deeper. The diameter of the fistula is still pretty good, but it's not, there is hematoma on top of that fistula. But as you go over, you can see clearly the problem. The stent is virtually floating in that fistula. The wall of that vein was so dilated. Remember, we said it's about 15 millimeter wall. These stents can be anywhere between 8 to 12 millimeters in size. So around the stent, there is some flow, some thrombus, and if the needle does not go into the stent, which it should not, ideally these stents are not, marketed to be cannulated, then you will not be able to get good flow. So even though it sounds great and it feels good on the distal part, there's a problem in the cannulation zone. The flow is 1200, but we cannot get this patient access. So here you will have to go back and do a surgical repair, remove that stent from an area, and then kind of fix it with a continuous flow, or may even require a interposition graft. All right, so let's take another case here. So this is a patient who's who's got a 12-year-old fistula, and then they transpose the upper arm brachiocephalic vein to create a secondary fistula, right? So the forearm fistula had some problems, so they created an upper arm fistula, what we call a secondary fistula. And then they started having some difficulty in cannulation. On exam, the fistula feels really good. There is a big transposition scar where they transpose a basilic vein to move it into the middle of the arm. And there seems to be a pretty dense edema around it. And the fistula cannot really be palpated, and we cannot see whether it's collapsing under the thing. So when you do an ultrasound, it looks really good. The anastomosis looks good. The brachial artery, so the distal part of the fistula looks good. This is not brachial artery. This is a brachial artery. And the distal body of the fistula looks good. The mid body of the fistula looks excellent. It's a large, mature, fistula without any problem. But then when you scan the fistula above, you see this big problem. There is a clot in the middle of that fistula, and then there is a big dilated, false lumen that has been created on the top of the fistula. This is where there is a tear on the anterior wall of the fistula, and now there is a second false lumen that has some blood flow, but because the blood doesn't have any place to go, it's just forming a clot in that top section. So here too, you will have to do a revision. There's another picture of that same patient. The top part is a false lumen. The blood is just churning around, cascading in that area, but there is no flow outside of that false lumen. So this would also require a surgical repair to fix that flow and get that patient, adequately dialyzed. Whenever we create a fistula, another common problem that can occur is what we call steel or distal hand ischemia. And this is something that I would want you to be on a watch out for, because these patients can end up getting really, you know, damaged, damage to their nerves, damage to their hands, damage to the muscle, if we do not pick it up at a early level. So I really wanted to highlight this part as well. So when a fistula is created, let's say this patient who's got a brachial artery, and this may be a proximal radial or a brachial artery to say cephalic vein upper arm fistula, the blood flow comes in from the brachial artery and goes up the cephalic arm. But the flow should keep going to the distal arm as well, the distal forearm. The radial and the ulnar should keep getting flow down to the hand, and the hand should be well perfused. So that's how it should be in a normal patient. In a patient with severe steel, the blood flow is coming down and going up the brachial artery, but the blood flow in the distal part is very low, and your distal hand may be getting minimal to no flow. This is what is going to be presented with a pale hand, so that the hand with a fistula may be dusky or pale compared to the hand without fistula. So it's a good comparison that we look at both the hands together. You may start seeing some wounds that are not healing in that hand, or they may start forming a ulcer in that hand, or there may be frank gangrene. It may be just over one area where there was an injury, and that doesn't heal, or it could be, just severe ischemic injury and damage to that arm. So this is something that we need to be very cautious and be observeful for. And the moment we see any sign of a distal hand ischemia, we should, look for that. And these are all the signs that should help you point towards that, right? Now, one of the things that I wanted in the dialysis units when I used to round early in my days was a pulse ox. And then the dialysis unit would not give me a pulse ox. But thank God, or, thanks that we have a pulse ox in every dialysis units now. And that's the easiest way of diagnosing someone with a hand ischemia. So if your patient complains of hand pain and they're having some symptoms because you may be worried that they may not be getting flow to it, just put a little pulse ox into the distal hand and onto the fingers. And if you're getting a pulse ox of 100%, they're great. If you're not getting a signal, then do this stuff. Before you stick the patient, gently occlude the inflow or right the anastomosis part of the fistula. Occlude the flow to the fistula or to the graft. Keep occluding for about 30 seconds, and you're not going to cut off the flow or cause a clot by that. What you're doing is you are lowering the flow into the fistula and pushing more flow into the hand. And if the problem is that there is low flow going to the hand, that maneuver should then give you a pulse ox. And what you've done is you've diagnosed a patient with low flow to the hand and a distal hand ischemia or a steel syndrome with ischemia, and you should get that patient in to be seen by the surgeon or the interventionist as soon as possible. So it's very important that we recognize these hand ischemic symptoms as early as we can. Once you diagnose them, or you send them to come and see us, we would do a quick ultrasound. We would look at the distal hand flow. We can identify what the flows look like here in this patient. As you go from the forearm, elbow down to the wrist, the flow, which used to be good in that wrist hand, now is getting really low. And that is a sign that there is a stenosis or likely hand steel, and we may need to do an angiogram to confirm that. Okay. So with that, I'm going to stop talking, and I'll be happy to take any questions if you have. Uh, Thank you for all that you do for your patients, and we at ASDIN are fully committed to support your work and support the dialysis access for every patient getting dialyzed. If you have any questions or if you need any help, reach out to us at ASDIN News or my Twitter handle, which is Kidney LSU, and I'll be happy to answer those questions. I'll stop questions and I'll be happy to take any, I'll stop talking and I'll be happy to take any questions if there are any out there. Any questions?
I haven't seen any in the chat, but I want to remind everybody, please feel free to unmute if you'd like to ask a question. We are here and available.
This is
Don't be shy.
Tiger time, so yes, all questions.
I have placed the link to the form that you'll need to complete to receive your continuing education for attending live in the chat. Make sure that you give that a click.
A quick question. How many of the units have a ultrasound, or is there any unit out there for the people who are in attendance that have a ultrasound available in the dialysis unit?
I saw a couple of people, well, at least one person that said, I wish we did.
Yeah.
I didn't see anybody say yes earlier.
No, and I think that is one of the new. So one of the videos that that's out there is if you sit down with your nurse or your nurse manager and they ask you, okay, what is it that you need? Make sure that the ultrasound be on top of the agenda. I think if we have an ultrasound in every unit, we should be able to identify these problems. Like you said, a lot of these problems with cannulation, a lot of these problems with those clots, or there is a false lumen, or there is an aneurysm, are all very quickly identified with an ultrasound. And the best part about an ultrasound is it's a one-time investment. Once you have that machine, all you need is a little gel, which is, next to no cost, and you should be able to identify a problem in an access for years from there. And these days they've gotten, fairly cheap compared to where they used to be. So I'm waiting for Apple or Google to come up with one of those generic ultrasounds that would be less than $100 or $200 that every unit should be able to have. So hopefully we'll be there soon. But like I said, encourage your docs to get an ultrasound. They can bring it into the dialysis units. The units, ultimately will get on board, and hopefully there will be an ultrasound in every dialysis unit.
I'll give you one more chance if anybody wants to pop on. Thank you so much for joining us, and we really do appreciate this collaboration, and I look forward to what you guys put together for us in our conference next year. Again, everybody, make sure that you complete the form in order to receive your continuing education for attending live. If you didn't catch it all, or even if you want to just review it, you will receive a link to the recording to watch this and share this with others later. I want to say Megan usually gets those out in about a week or so, maybe a little less. So thank you, folks, and take care.
All right. Thank you, guys. Have a good day.